6. We are this week and next week, and so kind of my plan was I know this week's coding roundtable is intense, so I'm going to pull it up. I'm going to pull up 3M, and then if we have time, we're going to go through the PowerPoint, which I have attached in the files section right above where you guys are chatting. So let me first share my screen, but I'm going to pull up 3M now. So give me 1 second. Give me one. Sorry, it can be slow. Well, I have the Citrix server. I don't know why it's, there we go. Okay. So with this week, once I get this pulled up, hold on 1 second, and then I'll, of course it came up on the other screen, why wouldn't it? All right, so what I did this week was I cut and pasted the coding roundtable into a Word document just so I could highlight it and show you guys a few things. So I realized that, you know, he or she lists, you know, all of these different procedures. First off, you know, you have to read what's in the body to ensure that was actually done. Sometimes, you know, they'll list, for example, a colonoscopy. And then they will, let's say the bowel cleansing was not appropriate or wasn't sufficient, and so they will only get to the sigmoid colon. Well, then you code as far as they get. So keep that in mind first and foremost. Second, this oftentimes confuses students. Please see dictation in reference to the subsequent biopsy of the left pleural mass. Every operative report, or, you know, it's going to be in the same chart. So yes, you're going to code it if you were coding the entire record. For this coding roundtable, you're not going to code this because this was done by a different physician. You know, you may have 30, you know, different operations that were done on somebody. I mean, depending on how long they were there. So, you know, the reason that they do their own dictation is, one, they did the procedure. Two, you have, you know, who did the procedure, so they get credit for it. And so just keep in mind, this is not done at this time. I mean, it's done basically while the patient's still on the table, but it's done by a different physician. So you're not going to code that. Because in real life, you will have the record and you'll have a different operative report by a different physician. And normally doctors who do this are OBGYNs or surgeons, and this is often done by, it can be done by a surgeon, but often it's done, you know, by a pulmonary surgeon. So, you know, and how they did it, the biopsy, I mean, we don't know, was it done, you know, via a CT, like I had one today, they did a CT scan and did a guided, or CT guided percutaneous biopsy of a lung mass. And so, you know, you don't have any information from this, so you're not going to, you know, be able to code it anyway. And also, please see dictation in reference to, you know, the biopsy that's getting ready to happen. And so it's kind of telling you, hey, you need to go look and see the dictation there. As far as back in the day, let me, first off, the chest tube placed. We're not going to code that. That is, you know, they'll put these in whenever there's, you know, certain types of surgeries, they're going to put in different types of tubes. And in this case, we're not going to pick this up. This is not going to be coded. Occasionally, it depends. When a chest tube is honestly coded is if patient comes in, they have a collapsed lung, they put a chest tube in, and then that's when, that's basically when you do code it. You don't code it if it's, if they're having some sort of surgery, and that's a normal, part of the procedure. And so same with the Foley. No, the Foley is not coded either. That's everybody who has surgery gets a Foley put in. The Foley is picked up by the charge master. It's just basically it is a supply. They insert the tube and that's it. So they'll charge via the supplies. So it's not something, with HIM coding, this has to be something that it requires breakdown of, what was done. It's not something you can just, charge as a supply, or it's not something you can, that's one CPT code is going to cover all of it, a single view chest x-ray. That's one, it'll be on the charge master. So these are things that we have to, think about and think about what's done. The red blood cells, we do not, let me just say, back in I-9, we did code these. Some facilities wanted them coded every time a patient got a red blood cell, or any kind of blood. So if they got 30 units, then we had to code it 30 times, which is very annoying. Sometimes they want us to code it one time. Sometimes they didn't even want us to code it because it can be picked up by the charge master. In I-10, because it is so difficult to find where they because this is basically all you get. You don't get what vein they put it in or what, where they put it. You don't get any of that. And so in I-10, it is required. So that way, we don't code that. So just keep that in mind. So we have a woman who is, she has ascites, and she has a pelvic mass. So here she underwent a paracentesis that was consistent with adenocarcinoma. You got to remember, this is indications for the procedure. This is not happening right now. This is what happened prior to why she's here to have this surgery. So she underwent paracentesis, she underwent chemo and repeat imaging, and so they brought her to the operating room today for debulking. And so debulking is basically getting all the cancer out is the best way to put it. So, they talk about the findings. There's no cervix because they've had a hysterectomy. The intraoperative surface of the peritoneum and the surface of the liver was grossly, and I think I've mentioned this before. What that means is when a physician or, any kind of physician is looking at a body part, meaning whether it's a liver or whether it's, whatever it is, if it looks normal to their eye, that means it's grossly normal. So that's, if it's abnormal, they may say it, it appears grossly abnormal. So that's what that gross means. So keep that in mind. It's not that it's like grossly, like gross. There were adhesions of the rectosigmoid. The right adnexa appeared grossly normal. There's again, there were induration of the omentum, but no gross tumor, meaning they didn't find a tumor, on the omentum. In the procedure, there was no gross tumor that was visualized. So, the patient's taken in, they put in the Foley cath. Here's first thing. And I think I've explained this before, a laparotomy is an incision into the belly. If they go in and do anything else, and obviously they did other things, you don't code the laparotomy. It's their way of getting in there. And so it ends up, laparotomy is an opening, where they open the belly up. And so it's considered an open approach. It's kind of like, any time a inspection type of procedure, goes on to do some sort of surgical, procedure, pelvic washings, whatever, the inspection procedure becomes the approach. So they open her up, and the first thing that they do is the pelvic washings were sent for cytopathological evaluation. And then the diaphragmatic brushings were obtained of the right hemodiaphragm. So that's our first indication of what's being done. Remember, the reason that they do anything diagnostic, meaning your seventh character, seventh character on your code, if they are looking to see if something is cancer, you code it as an X. So, with that being said, this woman has known cancer. If they're looking for, any type of evaluation by the pathologist to determine if the cancer is continual, if it's in there, that's what, they're doing. So first off, I'm going to go through this, and then we'll go and, switch over to 3M and look at it. All of this, is basically, remember I said you got to get everything, you got to make sure everything is secure, and you don't want to, it says it was identified and dissected. Don't let that confuse you. What that means is it's pushed out of harm's way. They are making sure that they don't clip the ureter, and so then there's going to be another issue. So the omentum was brought into the abdominal incision. An omental biopsy was performed. And then a frozen section revealed no gross evidence of malignancy. So, and I think I've explained this before, the frozen section is where, the patient's on the table, the specimen is sent to pathology, and they immediately look at it to determine, is it cancer or not? Because if it is cancer, what they'll do is then do further, they don't want to open you up twice. So that's the purpose of that. And then at this point, the peritoneal biopsies were then obtained of the right and the left, or the left and the right, in addition to what was palpated and thought to be a mass on the left side of the perineum. The recto sigmoid was sharply dissected from the left pelvic sidewall, and once freed, there appeared to be a mass that was biopsied. And the peritoneum, uterus was identified and put out of harm's way again, and a biopsy was obtained of the left sidewall mass. Okay, with adhesions being lysed, here is where this is a coding rule. Unless the adhesions are noted to be extensive, or it took them an extensive amount of time, and I may have already said this, you do not code them, the lysis of them. And honestly, I've seen, where you'll see extensive adhesions, you'll see, I've seen adhesions that have they've gone in to do a hernia repair, and the adhesions have taken, 3 hours to lyse down just to be able to, go in and do the surgery. So that's when it's coded. No gross evidence. The abdomen and pelvis were irrigated. Uterus were re-examined. They made sure they were working. There was lymph nodes that were enlarged over the iliac vessel that were harvested first from the left and then on the right. And they're doing this to determine, is there cancer in her lymph nodes? Then basically they put the bowels back into where they're supposed to be, and then everything's done. And then it gives you a list of specimens, and the patient's extubated. So before I even go into the coding, and this is one that, I apparently have some disagreements with things, but okay, they note that they did a right salpingo-oophorectomy. I don't see anywhere that they did a right salpingo-oophorectomy. They said they sent right adnexa to the pathologist. That could be anything, in my opinion. I personally, on this one, though this is not in the answers, they coded, I've voiced my opinion on this, they have coded the right salpingo-oophorectomy. I disagree with that. I think if, at a minimum, it should be queried to see if it was done. Because he doesn't discuss anything about taking out an ovary in a fallopian tube. So with that being said, if you want to engage with your professor on that, that is, but in real life, that is what I would do. I would not code it. I would think that it was one of those things that they said, okay, I'm going to do this, and then they don't do it. And so that's why that's why I don't agree with the answers. So I just say that, but I will give you all the answers, that, not give them to you, but go through the answers so you understand, what was done. So, okay. So let me go to 3M, and I don't remember what the age of the woman's name is. I'm just going to say 56 because that's my go-to name, my go-to number. All right, then I'm going to add my procedures. So the first thing they did, if you'll pull up she's 85. Okay, it doesn't matter. Honestly, it doesn't matter. So, it's not going to change anything. It just makes we have to make sure it's a female, because if you do a male, watch what happens when you do a male. Even if we do the right age. So I try to do, even if I just do salpingo-oophorectomy, hold on, if I could spell. Salpingoplasty. Interesting. Hold on. Let me try a different one. See, if I try to type in hysterectomy, is it going to really see no text found, or does not meet the age or sex edits? So that's what happens. So let me change it to female, and I will change it to 85. And then I'm going to add procedures. So the first thing they did was the pelvic washings. They, and if I pull up it was done right here, the pelvic washings were sent for pathology evaluation. So I'm going to do washings, and it was actually diagnostic because, remember, they're sending it, I'm going to go washings because I don't know if that's going to take me the correct way. Washings or irrigation of other sites. It was a diagnostic because they're sending it to cytology. It was of the pelvis. Let me see. Is it going to be under female reproductive? I don't think it's under that. You know what? It's not under irrigation. Hold on one second. Irrigation is putting in or a cleansing substance. Peritoneal dialysis. Wound irrigation. Interesting that it comes up drainage. Hold on, drainage. Taking or letting out fluids and or gases from a body part. I disagree with this code that they have. Hold on. IND of abscess, thoracentesis to... Bronchial alveolar lavage. Well, okay. See, I disagree with this because if you go under just washings, yeah, and peritoneal cavity, it goes to irrigation, but the answers have drainage, and I don't agree with that. I don't think they're draining it. I think that they are irrigating it out. Hold on one second. Administration, irrigation, putting in or on a cleansing substance. You know what? It's not well, they are kind of cleansing that out. This is where I disagree with the, let's see. Maybe that, maybe not. Drainage. Yeah, I can't get it that way. Let's see. How are we going to do it? Is it going to be anatomical regions? Peritoneal cavity. It was done open. It was drainage, no drainage device, and no qualifier. Oh, no device, no qualifier. Okay, they're using J, pelvic cavity. Oh, that's why. Hold on. And it's under anatomical general, drainage, pelvic cavity. There you go. Open. No, wrong one. No, go back. General. Pelvic. Open, no device, diagnostic. That is the right answer, but I don't agree with it. Drainage, taking or letting out fluids and gases from a body part. I really disagree with this. Again, you know, the right answer is, well, I'll have to take that up with the other professors, but I don't think that the answer that they provided is correct, because this is basically when you're doing if you look at the operative report, they're just washing it out. So it's not, how do I think it should be coded, Janice? I think it should be coded like this, but that's just my opinion. Irrigation of peritoneal cavity, using irrigating substance, percutaneous approach. It's not percutaneous approach. Hold on. It's open approach. So hold on. Oh, that did. So if you do washing, diagnostic, peritoneal, I think that's the closest that it's going to get. Peritoneal lavage. Hold on. Oh, and it's only allowing, you know what? That's not going to work, because that's wrong. My code is wrong, because it has to be an open approach. And so, let me see. Washings. Diagnostic. Or female reproductive. No. See, I don't even think I can do it this way. I think that's why they had to go drainage. This may be one of the things they correct when they do the update of I-10, because it's yeah, it's gonna, this can't be right, because they didn't do it percutaneous. So after all, I do agree with them, though I was going to fight that. Drainage, because drainage to me is not that. So, and then it was, let's see. It was general anatomical regions or pelvic. Oh, there we go. General regions, the pelvic cavity. I don't know that it said what, did it say what part? Let me pull this up. Oh, wrong thing. I didn't mean to pull up Excel. Click the wrong thing. Yeah, because it's not saying if it's, oh, it's because I'm reading plural cavity. I'm having, okay, then that was open and no device, and it was diagnostic. So no, it's not irrigation, Jennifer, but yeah, the approach is wrong, so we can't even go there. And this doesn't matter. This is for I-9. I'm just trying to get on with it. Okay. So our first code, which is the pelvic washings drainage, is, pelvic washings is drainage of the pelvic cavity, open approach. Yeah, Holly, you can't code it with irrigation, though, because of the approach. You're opening them up, and it has the, if you go irrigation, which I agree that that's the appropriate root operation. However, it doesn't have the appropriate option to do open, and the patient was definitely wide open. Okay. So the next thing they did was brushings. So if you type in brushings, brushings for biopsy. So are they doing a collection of fluid? No, not on that one. They're doing an aspiration of tissue samples. So they're doing excision. And in this case, it's the right-sided diaphragmatic. So, and you're not going to give me that. Okay, so I can't even do brushings. I'm going to have to do, it's going to be excision because they are doing, if you notice when I do brushings, it says your root operation is going to be excision, but 3M is not going to allow you to do that. It's not extraction, Michelle, because with extraction, that is more of, if you, let's see, it's more of like a foreign body that's, you know, if you notice, these things are not necessarily, they have to be forcefully removed. And so pulling or stripping off of or out of all of a body portion with the use of force. And with brushing, that's not what they're doing. So it's going to be excision. Michelle, if you find where that is, let me know. It's going to be other specified. It's going to be other specified, diaphragmatic. And this one gets me every time. I think I have to do general. No. It is going to be, because diaphragmatic is considered, that's the midline point on the human body. Yeah, but with a DNC, you are forcefully extracting something. You know, they're scraping it out, and, you know, that is forceful. It's different with brushings. It's just like taking a toothbrush and, you know, kind of rubbing on the side of something. It depends. I know that that's kind of confusing, but it really is not considered forceful. Okay, maybe it's under GI. And maybe it's not. Diaphragm. Let me pull it up the other way. That's right, it is respiratory. This one gets me every time. Respiratory, and then it is of the diaphragm right, and it was open, and it was diagnostic. Okay, so excision of the right diaphragm, open approach, diagnostic. Because every time I want to put diaphragm in the GI, as far as like where it's located, it just makes me think more of the, not that it's a GI thing, but just that's where they would lump it. Okay, so our next thing they did was the greater omentum biopsy. So if you put in biopsy, it's not fine needle. The greater omentum is, let's see, I think it's going to be, is it in pill? Let's see, let's try this though. I think that, yep, I was right. There's the lesser omentum, great. Okay, so what I did was choose GI. And then I did excision because they're excising it. And then I'm going to do the greater omentum. Oh, goodness. There we go. It was open, excision of the greater omentum, open approach, diagnostic. Then they did a pelvic lymph node biopsy. Okay, biopsy. The lymphatic system. They did an excision It was of the pelvis, and it also was open. So excision of pelvis lymphatic open approach diagnostic. Then they did a peritoneal biopsy. Wasn't fine needle. And the peritoneum, I believe, is going to be in the GI. Excision, yes. Peritoneum. It was open. Excision of peritoneum, open approach, diagnostic. Recto sigmoid biopsy. This indicates two different locations. So there is, when you use 3M, one of the good things about it is, and it was an excision, you have the rectum, and then you have the sigmoid colon. And remember, with the squares, you can click on multiple ones. So they did two different sites on that. It was open approach. And you have to do it this way, so I apologize. I'm just going to say no because, okay. So then you have excision of the rectum, open approach, diagnostic, excision of the sigmoid colon, open approach, diagnostic. And then the last two, which I completely disagree with, are the fallopian tube and the ovary. But so when they're taking out an ovary and fallopian tube, if they take out the entire thing, it's called a resection. That's the difference in the, excision and resection, because it's the total body part. It's the total ovary. So it's going to be female reproductive system. We're going to take out the right ovary first. It was open with a salpinate. Yes. It was also a resection. It was also the right. And so this is all of them. This is what you would code in this account. However, again, I disagree with this. I don't like it being drainage, but I don't have any control over that because the approach, they're not letting the approach be open. So I guess drainage is basically the only way you can go with it. So what questions do you have on this one? Because I know it's a lot. Oh, y'all are just feverishly writing them down. As in my class, it's not about getting the right answers, it's about trying. So I realize some of y'all, the last two, Aisha, the ovary and fallopian tube. What is harvested? Harvested. Let me see. Where, Katrina, where are you talking about? Where are you seeing the harvested? O7B. Okay. The pelvic lymph node biopsy. Highlighted in yellow. Practice. Oh, it just means harvested means they were taken. That's all. That's all it is. It's not. It's just they're over. You got to remember that lymph nodes are not in the iliac vessels. They are, this is considered, it's over them. So it's their location. And so they're in the pelvis. And so that's it. That's why it's considered the pelvis. It's just where, he's just being more specific on exactly where they were. And Jennifer, you're confused with the pelvic lymph node biopsy? Okay. Let's see. Okay. On how to code it, or is that what you mean? I didn't get the code, say it was ovary. Jennifer, are you talking about two for the fallopian tube? Hold on, I think I'm following two different ones. Okay, so Tracy, you're asking the code, did it say it was ovary? Yes, there's a right ovary and a right fallopian tube, though I disagree with these two. It's not proven to me that they were done. For the lymph node biopsy, honestly, if it's the whole chain was taken out, then that is when it's considered something else. This is pelvis lymphatic. So this actually is open to multiple. I mean, it's definitely not, saying it is one lymph node, or even if it is one lymph node, this is still what you would use. If it's two or if it's three, it's still this. You're not going to code it multiple times because it's saying it's lymphatic. It's not saying excision of pelvic one lymph node, or it does. And there's I don't think there's a left and a right on that one. But Tracy, yeah, I don't agree with those two. Those two are the two that I completely disagree with. That one's just I can't help that one. But these two I really think would need to be queried. You would need to, find out, okay, is there, I mean, you could look on the path report and see if if it did show a right and left ovary, but still, I mean, he doesn't talk about taking them out. He doesn't talk about, I mean, normally when they take out, they'll talk about cutting it, they'll talk about, removing it. And so that's why I disagree with it. So, but that's just, I'm sure your professors are going to love me for that, but I've already voiced my concerns and my opinion on this, so. Yes, Tracy, the only place I see it mentioned is right here. That's what oophorectomy means. So, and the salpingo is the fallopian tube. So, again, that's what these are, or that's what we get. Any other questions? Yeah, it's you really have to be up on it and know what, I mean, if you put in salpingo-oophorectomy, then it's gonna come up. So, and it's gonna say resection, and it gives you some examples, but any other questions? I can go through the PowerPoint if y'all want me to, or I'm willing to answer other questions you have. The PowerPoint has some examples in the back of it that that you can go through if you don't want to go through it now. And no, it's not safe to code from there at all. There's many times they don't do stuff that they say they're going to do, or, their intention is to do this, and then they get in there and this happens. that's why you have to read through it and see exactly what was done. Okay, so the PowerPoint does go into, what your different 7, these are the ones y'all are looking at now: OB, placement, administration, measuring, monitoring, excorporeal assistance and performance, excorporeal therapies. And this just gives you, your root operation I don't know if it's changing, for each one of these, but it does change in regards to what each one is. And so you have obstetrics, placement, administration, measurement and monitoring. This is a good thing to have printed out and kind of look at. Okay, well, I know that, this is going to be this and this one, like duration and function. That's different than, the approach and the whatever, my mind just went blank. So device, that's it. So let's look at the scenarios. So we have, nice if I actually read the scenarios. So mom was admitted into labor. She was dilated, and then they did Pitocin, and she progressed to complete dilation. They did a low forceps delivery, and but there was a 2nd degree perineal laceration, and that was repaired, and then a baby was born, and that she wanted sterilization, so she had a laparoscopic bilateral tubal ligation. So the things to concentrate on are, in all honesty, some facilities pick up the Pitocin augmentation, some don't. It's not necessarily required, but the low forceps delivery, they had a 2nd degree perineal laceration that was repaired. So with delivery, let me go to the next patient, because I need to make her of baby making age. Okay, so first thing they did was a delivery. So they delivered the baby. It was a vaginal delivery extraction. They did a low forceps delivery. Some places see they would pick up the induction of labor. In this case study, or at least in this slide, they are not. I would not coded given to augment active labor. I don't think she was in active labor. They did a laceration repair. It was of the perineum. It was 2nd degree because, let me see if that states it. Wrong one, hold on. 2nd degree perineal laceration. And there was no more repairs. And they did sterilization, but I don't see it on the screen. Let's see. Just gonna do other. No, I'm just trying to get out of here. Oh, wait. I thought I was in 99. Hold on. Extractions. Other. No. Delivery mother. Vaginal. I'm just going to say no accompanying procedure, just to make it go away. Okay. So you have, so far, the extractions of the product of conception, low forceps via natural or artificial opening. Introduction, this one is not on the answer sheet, but introduction of other hormone into peripheral vein, percutaneous approach, and then the repair of the perineum muscle, open approach. Now this is one that confuses even the the coders who have been doing it a long time, because this open approach doesn't seem right. With a perineal laceration, there can be a type 1, so to speak, or first degree, second degree, third degree, and fourth degree. Fourth degree goes all the way into the rectum, and it seems in I-10 that it groups them all, you know, kind of in this one. So anyway, then they do a sterilization. Tubal ligation. I don't know that they discuss what type they use. Oh, that's the wrong thing, sorry. Let me go back to it. Laparoscopic bilateral tubal ligation. So we don't have any other information. Okay. Bilateral, laparoscopic, percutaneous endoscopic. No, there was no robotic assistance. Okay, so then you have occlusion of bilateral fallopian tubes, percutaneous endoscopic approach. So these will be your codes for that delivery. And remember, for OB, they're always going to start with a 1. Okay, so let's go to scenario 2. Patients admitted with a non-viable fetus. They do a prostatin capsule, which was placed intravaginally, and then they went on to have a spontaneous expulsion of a single-born female, and then the patient was discharged the following day. So in this case, here, I'll just do next patient. So for, you know, when they do any type of insertion, basically what they're doing is doing an abortion. It's treatment. I've never in my entire career seen an abortion done electively. This is just to treat, you know, the miscarriage. Unfortunately, and we run into billing problems with this, that unfortunately, it ends up being, if they deliver the baby normally, like what it says, that they an expulsion means they vaginally deliver it. Spontaneous means vaginally. So they did manually assisted delivery. There was no accompanying procedure. So that is considered, you know what, that's not coming out right. Yeah, I don't agree with this. Extraction, products of conception. Wonder why it's not. Artificially terminated. Extraction. Let me see how that. See, that's not right either. Interesting. Hold on. I wonder if they did. Yeah, they did it that way. Interesting. So with this abortion artificially induced elective, artificially terminating a pregnancy, and actually, yeah, see, I don't agree with this. Manually assisted spontaneous abortion codes to delivery because it captures the procedure objective. The objective is not to terminate the pregnancy, in this case, the fact that abortion will be identified in the diagnosis code. So actually, it is, oh, I'm sorry. It's going to be what I had before. The answer thing is not right. It's manually assisted. They had no other. So it would be a delivery of products, external approach. Tracy, how did you get the A and the 7 and the ZZ? Let me type that in. 10A07Z. Oh, it's not gonna let me. 1A0. It's, let's see, 10A0. It's not open though. They're not opening her up. It's going to be via natural or artificial opening. And then that's what the code would be right there. Well, why didn't it show it? 1A via natural. So it should be 10A07ZX. And that's what the answer has, but that is interesting. It's going a different way. Oh, crud. Hold on. One 0A7. Yeah, that only matters because of the so that's it. Sorry, I'm obviously put it in too many times. So I'm wrong initially. So it should be 10A07ZX via natural or artificial opening. So the answer on the this is incorrect. No, it's not. It's correct. Good job, Tracy. Yes, definitely. Okay, we got 3 more. So we have a woman who has carcinoma of the stomach with mets to the ovaries. They do exploratory laparotomy, but it was so densely attached to other structures it could not be resected. However, a total abdominal hysterectomy and bilateral salpingo-oophorectomy were accomplished, and the patient returned to her room in fair condition. Then chemo was given, and then on the 3rd day, a pleural effusion developed, and so they put in a chest tube. Okay. So, let's do, here I'll delete that one. So they do a hysterectomy. And it was open, total abdominal hysterectomy. And it was open. And that's all they did on that one. So we have the resection of the uterus, the resection of the cervix. Then we have that they did chemotherapy. Chemotherapy infusion. We don't know what it is. It's going to be the central vein. This is where you have to really have more detail in order to be able to code these appropriately. No infusion of drugs. So introduction of other anti-neoplastic into central vein. Let's see if it actually says the central vein. No, that's where you have to have more detailed information. And then we have a chest tube that was placed. So insertion of, let's say, chest tube. That's not going to go that way. So I'll do tube. So I'll do catheter. Let's see if that works. For drainage in the respiratory. It's not going to give that to me. Let's see. Let's do general and then chest wall. Open approach, drainage device. Okay. Yes, Amanda, I agree. I wanted to see what OW908. Oh, that was in that one. She did introduction, drainage of the right pearl with drainage device, percutaneous approach. Okay, maybe that's. Let me go drainage. Tube insertion, chest, right pleural cavity. That does it better. I guess it was percutaneous, though. I would think it would be more. Good point, Holly. It is. I'm sure it is easier if you just type in chest tube. Let's do it that way. Chest tube placement. There you go. Drainage. Yep. There you go. I just wasn't. I consider that. I don't know. I consider that an open approach, but I guess I can see the percutaneous. Okay. So, let's go to the next one. Incision and drainage of right foot abscess. That's it. Oh, and then the hyperbaric oxygen therapy and daily whirlpool treatment. So you have, I was trying to delete those. Okay, so you have drainage, of the right foot, which will be the skin of the right foot. No drainage device. I didn't see it was qualifier. Then they did the hyperbaric chamber. Oxygen wound treatment. It was intermittent because continuous means ongoing. And then they did what was the last thing? Whirlpool treatments, I believe. Yeah. So whirlpool therapy, integumentary of the lower back and lower extremity, lower back, lower extremity. So in this case, these are the ones you would have. Drainage of the right foot, they did the hyperbaric oxygenation, and then the wound management therapy. So those are your three for that one. Then they did a video EEG, and that was it on that one. So EEG, monitoring, yes, and no, it wasn't intraoperative. It was external. So monitoring of the central nervous electrical activity, external approach. And then last one is patient was admitted after a fall, X-ray splint was applied, no other treatment. So they did a splint of the right humeral neck. Back to 3M. Yes, Tracy, you are correct. So they do a splint application, which is immobilization. And then it was of the right lower arm because it was the radial. So lower arm, right, there it is. So immobilization of the right lower arm using a splint. Do you guys have any questions about any of those? Or anything else while I'm still here? Excuse me. None? Yes, Tracy, it takes us all practice. I mean, honestly, as you see, I don't like how some of this goes and how it does take some time, especially for procedures. Diagnosis, not so much. I'm going to do that, Aisha, next live lecture. I couldn't think of what it was. Always grafted to the aorta. That's a good question, Jennifer. Let's see. Using the subvenous vein. No, it can go, let's see. Let me just see something. No, it can go from the coronary artery. Yes, Holly, you don't have it, and you actually are you doing the RHIT exam, or which exam are you looking at? CCA, I'm not sure about the CCA. I'm trying to think if I was allowed to use my book. Yeah, I think on the CCS I was allowed to use my book, but it's you're not, they don't have access to 3M, no. And on the RHIT, you will not be allowed to use your book. And there is, on the RHIT, they'll have scenarios such as, you know, they'll give you the codes and then give you a scenario, and then, you know, A, B, C, D, you know, you choose which codes are correct. So I'm not sure how they do the CCS anymore. I don't know if it's all multiple choice. It may be all multiple choice now based upon the same thing, but I may be completely wrong. So back when I took it, but that was in '98 for the CCS, and that's a long time ago, that was, it was not. As far as the RHIT exam book, Tracy, no, not necessarily. For the RHIT exam, you have, it'll just be multiple choice, but you will have what is, you know, they'll give you a code and then give you the what it says. So if it was procedures, it would give you, you know, this code and that, and then another code and then that, and they'll give you A, B, C, D, and then you have to, it's a lot easier actually because it's a lot quicker. You're not actually having to assign the codes. If I can spell. Let's see. That's the one I recommend personally. I have no reason, but other than that's the one that I've seen the most. You know, that's the one that, you know, you'll get. He is Merida, maybe it's a she, writes a lot of books. And so this is the best one. So if you know, as far as CCA, I don't know. I have not, you know, taken that one. You know, you can always, I would probably go with this one just because I recognize yeah, it's a HEMA based. I would probably go with anything a HEMA based. You know, that's my opinion. Because they'll give you practice questions on, you know, what to expect, what to, you know, what it's going to kind of entail, that type of thing. I was hoping that maybe it would show like an example of it, but it's not. Anyway, that's what I would, yeah, that's a great idea, Holly. Any other questions? All right, guys. Well, I hope you all have a great week, and I will see you all here next Tuesday at the same time. Okay? Thank you.